Good afternoon, everyone, and welcome to Husky Maternity Bundle Payment Program Office Hours. Thank you for joining today. I am Fatmata Williams, and I work for the Department of Social Services and co-lead the bundle development with Dr. Bradley Richards, who cannot join us today. So next slide, please, Tiffany. Okay, so the meeting ground rules. The forum is being recorded and will be posted on our YouTube channel, and the meeting materials will also be posted on the Husky Maternity Bundle website. If you're not speaking, please remember to mute yourself and also limit the use of the chat for Zoom technical and audio issues only. And when it comes time for questions and answers, please use the QA feature or raise your hand to ask questions. Next slide, please. Our goal for today is to share the program status with you all on how we're moving towards key implementation activities. We will review the case rates for payment year 1 and answer your payment-related questions. We're also going to review some programmatic refinements that were made in response to your feedback, and will be available to answer questions regarding the program. Next slide, please. So now to give you some program status updates. As you can see, there are some things that we have recently accomplished. And in response to your feedback, we were able to revise the launch date for the Maternity Bundle program, and that would occur the 1st of January, 2025. And we have accomplished some things recently, the actuarial modeling and program testing, some draft case rates, some historic performance reports, some provider resources and video guides, and frequently asked questions, as well as quality measures guide and billing examples. And there have been considerations of program refinements. Some of the current priorities that we are working on. DSS has provided maternity bundle practices with their final first payment year case rate letters. That was done Thursday, October 31st. And we also shared 2 new provider resources, the 835 test files and encounter form template in response to provider requests. We have also made great progress towards obtaining a state plan amendment approval in October by formally submitting the SPA. Since we have been working with CMS informally over the past 2 years, so we do expect to get our SPA approved and soon. Lastly, in the near future, we are planning to publish a provider bulletin for this program and share a test file for the supplemental payment reports, which we will provide to support accountable providers' ability to attribute TIN level payments among providers and practices. And some of our upcoming initiatives are the test files for supplemental payment reports, as well as performance year provider reports. Next slide, please. Okay, so I believe I'll hand it over to, is it Grace for the, okay, thank you. I'll hand it over to Grace now.
Thanks, Fatmata. Hi, everyone. So I will go over the performance year case rate files that you guys probably should have received at this point. Tiffany, if you don't mind. Yep. So earlier this year in March, DSS have provided a set of case rates for each of you that have had more than 30 episodes. So accountable providers, everyone should have been receiving a draft case rate information We also then in August share some supplemental details to help your internal analysis to verify the logistics of or the case rate, just to have a better understanding. So we've shared those information for the draft case rate, and the reason we call it draft obviously is because the data we use were for based on an older period of time. So just a reminder, those draft case rates and supplemental information are based on deliveries incurred between 10/1/2021 and 9/30/2022. So after that point, obviously we've collected a lot of information, and we'll go over some of the changes we made in a later slide. But we do reflect a lot of feedback and make some programmatic changes and updates. And then now, just recently, we've refreshed the case rate using a more recent period of time. So the refreshed case rates are based on deliveries from 10/1/2022 to 9/30/2023. And we use that 1 year worth of deliveries, look at all the claim histories, and refresh the case rate. And those case rates you just received will be effective as of 1/1/2025. So after the program go live, we'll keep working. We will keep monitoring changes in member access, practice revenue, and billing patterns to ensure that the rollout of case rate payments, the setup occurs as designed, and to preserve, to make sure Husky members still have sufficient access to care. Afterwards, DSS will continue monitoring and will rebase the case rates less frequent than once per year to account for potential changes in each of your practice's member risk mix or the services that deliver over time. Next slide, please. So this is a snapshot of, part of the information you've received in your letter, right? Like I said, these are all information based on a new period of time, and that is for delivery between 10/1/22 or 9/30/2023. So this is 1 year of delivery events. So in this table, on the top row, you will see your practice's specific name, your billing tax ID, and the payable Medicaid ID. So what we did here is we looked at all the AVRS associated with your specific TIN, and we looked at all the payments that have made to each of the AVRS, and then the AVRS who has received the highest revenue is defaulted to be the Medicaid ID that will be receiving payments. The bottom of this table shows all the information we've used to actually calculate your case rate. On the very left is attributed episodes. So those are the episodes we use your claim history to identify, to believe that you've been providing continuous prenatal and postpartum care for, and those are considered your attributed episodes. And for all of you, obviously, you should see more than 30 episodes. The cell on the right are all the first trimester fee-for-service payments for those attributed episodes. It's not for every single episode, it's for those however many attributed episodes we indicated in the cell to the left. And also just want to note those first trimester fee-for-service payments are only for the maternal care services. If there's anything we don't identify as maternal care related, we're not included in here. To the right, those are similar ideas. Those are going to be the second trimester, third trimester professional delivery costs, and postpartum fee-for-service costs. Again, those has to be maternal care related and has to be billed by a maternal care related provider specialty. And then to the right, you will see the second trimester, third trimester delivery and postpartum care costs per episode on average. And those should be in thousands, right? So to the right, then we based on the claim history, estimate the average month of payments you would have received if the program were in place during that period of time. So we looked at all the claim history. We estimated, if the program were already alive, from 2022, how many payments you would have get. So that we want to understand, how many months of payments we need to average out for those costs per episode. Then obviously use the total cost per episode, divide the average month of payments per case. Well, you will be able to see that is the year one case rate, as highlighted. Then to the right, there is a case rate add-on payment. So some of you will see $7, some of you will see $21. And that is because some of you decided to opt out of the doula program. So if you opt out of doula program based on the survey we asked not long ago, you will see $7. But if you did not opt out, you opt in, then you will see $21 PMPM, and that will be added to the year one case rates. And then all that together will be the PY1 case rate with add-on payments. Again, to note that $14 extra for doula services will be reconciled at the end of the year. Right, next slide, please. So the next two slides, as Tiffany is showing on the screen, this one and the next one, those are some very detailed description of each of the components I just went through. And I believe those are also part of what we've included in the letter you sent out to you all. So those are just some technical details you can refer to if you would like. And please feel free to let us know if you have any questions. Right. So this slide is what I mentioned earlier. Since we did receive a bunch of feedbacks from you all, we've considered them carefully, and we've reflected some of the technical adjustments to get to the final case rate. So first adjustment we've made is the maternal care provider. As I mentioned, when we do case rate analysis and calculation, we carefully look at the claims billed by the maternal care related specialty type. And in the dry run, in the first version of the case rate that we shared in March, we did include family medicine physicians and family nurse practitioners as the maternal care specialty types. But, based on feedback, I think for the most part, those two specialty type will only provide services that are unrelated to maternal care. So we decided to exclude them from all the case rate. What that means is that, after program go live, all the claims billed by these two specialty will remain to be reimbursed fee for service. Those won't be covered by case rate anymore. The second updates we've made is to exclude episodes for members with other insurance coverage. So that was from a question asked about, hey, if we have members who have a commercial insurance coverage, they will require global billing, and that obviously is not what we encourage here. So what are we going to do with that discrepancy? So now the solution is, if the member has a different, such as commercial insurance coverage, you go ahead and bill global codes per usual, because those members will no longer be covered under this program during the month where they have other insurance coverage. So how it works is, in a month, if the system identify a member has other insurance coverage, it will automatically return back to fee-for-service payments. But for another month where this member loses other insurance coverage, we will allow this member to be re-triggered and enter the program. Next updates we've made is about the place of service. So for the dry run, we only allow triggering event to happen at the place of service 11, which is in office setting. But understanding sometimes those initiation of care will happen in some other settings, such as 19 off-campus outpatient hospital or 22 on-campus outpatient hospital. We also will allow triggering events to happen in all three settings. The next updates we've made is about to exclude the comprehensive preventative medicine E&M code 99381 to 99397. So those are codes we also hear about. Those are usually for the annual physical. So we, as imaginable, those are probably not related to maternal care necessarily. So we decided to exclude those E&M code from the triggering codes. Last but certainly not least, we heard a lot of acquisition that knowingly will happen in 2025. So we decided to combine those experience to calculate the final case rate for the entity that acquired the other one. So for instance, if an entity A will be acquired by entity B, both of their experience are combined into calculating entity B's case rate. Okay, so those are all the oh, thank you, Tiffany. So next few slides, we'll talk about the MFM, right? So after carefully considering potential operational and actual consequences, DSS confirmed its decision to include MFM care within the maternity bundle for each one. So that is to serve several goals. The first goal is to align incentive across OB provider specialty. We also want to ensure the inclusion of higher risk patients in program and to reduce complexities in program design and operations related to MFM billing and the impact of attribution changes. So we do understand the fact that including MFM sometimes could cause accounting challenges in terms of where the funding goes to MFM. So we were able to provide some supplemental information to say, based on the experience we've used to calculate the case rate, what have been the MFM's performing services percentage, right? So whether 10% of services were performed by MFM or 0, based on the history, those are what we also provided in this set of letter for you all. Obviously, for some of the providers, you have not had any MFM historically, so you won't have this information. But for the ones that have had MFM, we included this information in your letter as well. Also, we would like to note, in recognition of provider feedback on this topic, DSS has planned to continuously monitoring, review, and reassess the impact of MFM provider inclusion following the program go live. And then if there's, if we see necessity of make any change, we will definitely share that with you all. Next slide, please. So as mentioned, this is a second table you will find in your letter for some of you. First row is similar with what we've mentioned. It will have your practice name, your billing tax ID, and your payable Medicaid ID. So these should be the same with what you will see in your first table. But the second part of the table indicate the total trimester 2-3 delivery and postpartum fee-for-service payments. And this should match exactly what you see in your first table. But the second part here is the maternal care dollars by the attributed MFM provider. So as I mentioned, this indicates how much of among the first part of the cell, how much dollars are actually reimbursed due to services provided by MFM. I do want to note, we strictly use the performing provider taxonomy to identify MFMs. And then the last component here is to indicate the percentage of dollars that were part of the case rate were actually performed by MFM. And we also included some key terms to, again, help you refer help you to refer to some, details of what we're showing each of the cells, so you can have a better understanding of what we're trying to share here. Next slide, please. Right. So as I mentioned, in both tables, there is a cell indicating who will be the Medicaid ID receiving all of the case rate payments. I want to reiterate, when the program go live, all the case rate payments will be made to one AVRS. So in the letter, that AVRS is indicated on the right corner, top right corner of your chart. But you obviously can let us know if a different Medicaid ID you want to use to direct payments to. And please share that information to your CHNCT representative by November 15th so that we can accurately reflect those information in our system. Okay, I think that is all I want to touch on for the case rate payment. Thanks, Tiffany.
Thanks, Grace. In this next section, we'll go over a few programmatic refinements that DSS has made in response to provider feedback. So the first one we're going to start with is new trigger event guidance for Go Live. This update is being responsive to provider feedback around how providers will be reimbursed for patients who are pregnant later in pregnancy at the time of the program's January 1st go live, particularly for episodes where the trigger would start in the third trimester. After reviewing actuarial assumptions and confirming operational feasibility, DSS has decided that for the first program of the quarter, we will only allow trigger events in the second trimester to initiate case rate payment. This is being done so that for the first 3 months, just to ensure that providers are receiving the full case rate payment for the duration of the episode during this transition period after go live. This is limited only to the start of the program for the first quarter. And as a reminder, as Grace might have mentioned, this is really not going to have any impact on your final year 1 case rates. As a reminder, those were based on your practice's historic utilization. So that means practice patterns for treating patients who are seeking or changing care later in pregnancy or in postpartum. Those kind of practice patterns have been factored into the case rate. What this means for practices is that effective January 1st through March 31st, trigger events in the second trimester only are going to be able to initiate case rate payment. So you will not be able to receive case rate payment for patients who are in the third trimester or postpartum period. Those will continue to be fee for service. And then giving you guys a little bit of a softer transition into case rate payments effective April 1st, 2025, that's when practices can begin to trigger, can submit claims with trigger events in the second trimester, third trimester, and postpartum period. And each of those trigger events would initiate case rate payment. Next up, we have some updated guidance around pay for reporting measures. So as a reminder for this program, there are 10 quality measures that DSS will utilize to ensure high quality among the practices. There are 5 pay for performance measures and then 5 pay for reporting measures as shown on this slide. For the pay for reporting measures, 2 of them, I believe, contraception and preterm birth and labor will be reported through claims data, so nothing needed from providers on that end. But for measures 8 through 10, doula utilization, breastfeeding, and behavioral risk adjustment, these measures will require data submission through the encounter form. The encounter form has recently been posted on the DSS website, and it's very similar to what is used for the OBP4P program for practices who are familiar with that and participating already. So one of the updates around the pay for reporting measures, we wanted to highlight that for practices who have opted out of receiving the doula care add-on payment, those practices do not have to submit reporting data for measure 8, doula utilization. And that means for the rest of their reporting measures, if that applies to your practice, those measures have been re-weighted ever so slightly. So instead of the measures being weighted at 6% each, it's going to be 4 measures weighted across 7%. The other item to call out, this has been reflected in the quality measure reference guide that is also on the DSS website online. We did add a little bit of guidance around the encounter form submission threshold for the 3 measures that will be submitted, that will be submitting data through the encounter form. So for doula utilization, because there is going to be a true-up reconciliation process at the end for recognizing the doula care add-on payments, we are going to require 100% encounter form submission for the practices who are receiving that add-on payment. And then for measures 9 and 10, breastfeeding and behavioral health risk adjustment, that will require a 90% encounter form submission to meet the requirement that you've submitted payment for that measure, or you've submitted data for that measure. And then the last update we wanted to give is around the CART code on electronic remittance advice. So DSS recently conducted a provider survey to request feedback on the proposed CART code. As a reminder, just stepping back a little bit, once the accountable provider initiates the case rate payment, DSS will process that trigger event in the claim, and that claim and all subsequent claims will be zero paid and receive the case rate going forward. When that payment comes through, the system is going to assign a unique EOB code on the remittance advice, and the 835 will also have a specific CARC code indicating the reason for the claim payment or the zero pay payment. And so originally DSS had proposed using CARC CO97. And we received a couple of questions around this, and that was the reason for initiating the provider survey to make sure DSS is using the code that is responsive for and best for most practices. Based on survey results, most practices stated that they prefer the change to CO245, or they didn't mind making that change. They were good with either of the CARCs. So based on those results, the updated CARC, which is reflected in the 835 test file that was recently shared with the case rate letters, has been updated to CO245. And I also wanted to flag there was another question that came out that was part of the provider survey around who will have access to the supplemental payment reports. The majority of survey participants responded that all practices under the accountable provider, or all providers under the accountable provider TIN, should receive access to that report. So that's the direction DSS is going to take that under. All providers under the accountable TIN will receive access to that supplemental report. So in terms of next steps, just wrapping up real quick, just wanted to remind with the case rate letters, there are a bunch of different new provider resources, as well as some updated resources that are now on the DSS website. So the new ones include the sample 835 test file. There are some notes at the top of the test file, so those will need to be removed to be processed. But you can reach out to DSS if you have any questions around what you're seeing in the mockup file. DSS also provided the sample encounter form, again, pretty similar to the OBP for P encounter forms. So this should be pretty familiar for practices. And then just reflecting some of the technical adjustments that I just mentioned in the previous slides, we have updated program FAQs, an updated quality measure reference guide, and an updated code list will be posted to the website soon. As a reminder for next steps for practices, if you would like to indicate a different Medicaid AVS ID to receive case rate payment, please request that change to your CHN Provider Engagement Service representative by the 15th of this month. And again, additional information can be found on the DSS website. So we will move into the question portion of this slide. I don't believe I saw any questions come through in the Q&A, but if folks want to just unmute and raise your hand, we can also go about it that way. Christine?
Yep. Hello. Can you hear me?
Yes.
Okay. Hi. Thank you for this great update. This is Christine Masati from Yukon Health. We did submit a question through Kimberly last week. So I don't know if you're working on this, but I'll just throw it out in case you can answer it. But it was a question about billing monthly with the defined trigger code. So that's not how we currently bill. So we're questioning, apologies, I'm just going to read this question. So should we be billing multiple visits with a trigger code during the month if the patient presents more than one time per month?
I can take, I think, a first stab, Grace, if you want to jump in too and make sure I'm not misspeaking. I believe practices starting in the second trimester, you can go ahead and submit a claim with the trigger event codes. So that'll be an E&M and then specific diagnosis codes. The code list is posted on the DSS website. Once you submit that, you technically don't have to submit claims afterwards. The case rate will recognize that, or once you trigger that event, payment will be remitted to practices on a monthly basis. The caveat I will say is that is unless that is assuming that your patient isn't seeing other practices. So it is recommended, if possible, to submit the trigger events on a regular basis if you're able to. Grace, anything else to add?
Yeah, Tiffany, I want to be extra clear here, Kristen. So basically when the trigger happens, right, as Tiffany was saying, the case rate kicks off, and no matter what happens until, either end of this whole, postpartum or someone take over the case, you will continue to get the case rate. But we do want you to bill every single service you've provided. That serves multiple purpose. That really helps us to understand how many services you've provided to each member, so that when we evaluate case rate, we can say, hey, in a fee-for-service setting, what UConn would have got and what the case rate payment has made to them, so we can check to see, evaluate whether the case rate really make each practices whole. So for sure, we want to be able to identify services you've provided. Another question is, do you need to provide all the trigger code every single time, right? As Tiffany mentioned, you shouldn't need to. However, you don't know what the members go to. You don't know if they seek another help from another provider. Because you don't know if there's another trigger and you will get case rate. So if you really want to ensure case rate payment come to you every single month, the safest way is to keep billing, adding those diagnosis code to your claim to make sure, we can capture as much of, services as you've provided. So that will be our recommendation, if that helps at all.
Thank you. So let me take my hand down. So apologies for that. So just to make sure I'm understanding, so as you're saying, if we don't bill the case rate monthly, there could be another, if the patient happens to go to another practice, then our case rate would get discontinued, correct?
Correct. So I want to be clear here. So if let's say for this month, you triggered a claim, you triggered a case rate. Next month, the patient went to a different practice, and then that practice, like that case, that episode get attributed to the other practice.
Yeah.
But if you still had a case rate service, you will still get that month of case rate payment. But in the next month, if you don't have any trigger to claim the episode back, your case rate will stop.
Yeah. Okay. And we have no way of knowing if the patient went to another practice, right? So if it's outside of our group, right, we'll never know. Okay.
Exactly. Until afterwards. Afterwards, you say, hey, I don't receive this case rate for this member. What happened? Well, that means the member must have gone to the other practice either the month before or that month.
Yeah. Okay. So I have another question, but a follow-up to that is, so if in January they came to UConn, we billed the trigger rate. And then in February, let's say we didn't bill a trigger code, but they happened to see another provider. We wouldn't get paid that case rate. But then if they came back in March, we would get it if we billed the trigger code. So it's best for us just to make sure that we're seeing these patients on a consistent basis and billing the trigger codes at least once monthly.
That's the safest way to ensure continuous payment. Yes.
And then the reason for, I want to make sure I'm understanding you correctly. Then the reason for, let's say the patient was seen 2 or possibly 3 times within a particular month. So in the month of January, we see them 3 times. We would want to submit that encounter data to DSS, even though we're only going to get 1 case rate payment. We want to submit the encounter data because DSS is tracking the encounter data for evaluation prospectively to then develop the, I'll call it calendar year 2026 case rate. Correct? Am I understanding that correctly?
Yeah, so the calendar year 2026 case rate. So first of all, we don't know if we're going to refresh the case rate every year. As mentioned, it will be less frequent than once a year. So it can be once a year, it can be once every 18 months. That frequency is yet to be determined.
Okay.
But let's say if we decided to renew the case rate once every year. then yes, so all your claim history will be used to evaluate if your case rate, wherever your case rate needs to go. That's why I said it's very important to make sure the services are processed and recorded in the system.
Yeah. Okay.
And also to note, there is a timing there too, right? For instance, in January, a member comes to UConn in early January for their second trimester visit. You build that trigger event, the system recorded, UConn had this service on let's say 1/5/2025. But at the end of the month, this member goes to a different practices for some reason. And that practice also builds a trigger event for the same month. The system will use the last in chain provider to say, because the other provider built that trigger event at the end of the month after UConn, that starting from February, that claim will be attributed to the other practice. So the timing matters too.
Yeah. Okay.
But it doesn't mean UConn won't get anything, right? UConn will still get fee-for-service payments for the second month, but it just like, on a continual basis, maybe in March, you won't get that case rate.
Yeah. Okay. Like you're saying, timing matters. Okay.
Yep.
All right. Thank you. And then one additional question. I don't know if you can answer this. The question that was posed to me to ask was, how should we be billing the delivery? Should we no longer bill the global delivery charge since we are billing monthly? And instead, should we bill the delivery and postpartum care, or just the delivery with postpartum care billed with the case rate codes, trigger codes?
So if you've been billing, in the past global code to indicate a series of services and delivery, then when you switch to billing, on an ongoing basis, we obviously don't want you to use global codes anymore. We want you to use the specific code for delivery only, right? There's delivery codes for C-section delivery, there are delivery codes for, vaginal delivery. So please just go ahead and use those specific codes for unbundled services.
Okay, so unbundled, okay. And then we would bill the delivery and the postpartum care separately then, right? Because like you're saying, it's unbundled.
Yes.
So delivery and postpartum are billed separately.
Absolutely. We want to know there are postpartum trigger as well. So as I said, those ongoing services should be recorded on their own. So yes, so we would like to see this delivery event billed separately than any prenatal or postpartum care services.
Yeah. All right, thank you. That answers our question.
Thank you. Caroline, I see your hand.
Yes, I have a question about unbundled billing. In another meeting, we were advised to bill like we typically would. The RVUs for a global are different than an unbundled. So if the doctors are getting paid by RVU by the company, that doesn't work. That doesn't seem right.
So Caroline, do you mind to remind us what was the concern using unbundled codes?
So I don't have all the RVU amounts, but I'm assuming that the global RVU, which is all of the prenatal care, the delivery, and the postpartum visit, is a higher amount for the providers to bill. So if they're not billing for the prenatal care at all as an RVU, I don't know if that will work for them. And we were told to bill like we normally would bill.
Are those for the members have like other insurance coverage?
No, if we see a Medicaid patient straight through from beginning to end, we bill the global fee. And we were told that we should continue to do that once this program starts. Because you're not paying the claims fee for service, but
So
our purposes, reporting purposes, the RVUs will be reported correctly.
I don't know what RVU stands for, Caroline. You might have to remind me, but basically you won't get fee-for-service payments along the way. That's true. However, you will get case rate. If you bill global codes instead, what happens is that you don't have those ongoing trigger. So you will pretty much just being reimbursed fee for service for those events. Because there's no trigger, right? There's nothing in a system to say, hey, your practice started taking care of this member, hence we need to start giving you case rate. That won't happen because you don't build those ongoing, trigger events.
Okay.
I don't know if I understand your question fully, Caroline. If I missed something, please let me know.
Okay, I'll have to go back and look at everything again.
Thank you.
And Charles, I saw you'd raised your hand if there's anything you wanted to add as well.
Not anymore. Grace clarified it.
Great. One question kind of along similar lines popped up in the Q&A, asking for the reason for changing away from global code billing. I think basically the reason is that to initiate case rate payment, there needs to be a way to track and be able to look at the services that are being delivered. So that's the biggest reason. Grace, if you have anything else you want to add in terms of additional detail behind that decision.
Nope. I agree.
Susan?
Yeah, I just wanted to further just have additional questioning about the RVU. So most of our providers do get paid based on an RVU value that they bring in, and that is based on the codes. And obviously the codes for the global delivery are significantly higher than delivery only. So this is going to impact how we pay them. It's not going to impact reimbursement from Medicaid, but it will impact how we reimburse our physicians. So I'm just not sure what the workaround is if we're not supposed to be billing for these global fees.
Yeah, and so this is Francis, I'm a revenue cycle director, Starling. Yeah, I think since we moved to the kind of that revenue value unit calculation as a reimbursement area for our providers, I guess the questions are, what is that impact, right? So global versus unbundled, I think, or something like I think those are the two things we're looking at. And so yeah, I'm sorry.
Right. I mean, right. Just a significant difference between a global maternity package where I think the RVU is I think it's like 73. I just looked it up. And then if we're billing just delivery only, the RVU is 24. So that's a significant difference for our providers.
So I think what we're going to need to do is, probably reach out to, I mean, I don't know what we have, but we might need to reach out to physician compensation and that's it on the village side. And, like I said, like before, work RVUs are not really like what we do revenue cycle, but I would think we need to give a heads up to physician compensation that there's going to be this change and that it has a material effect. And I think that's where the conversations need to start. Just my 2 cents. I don't know if specifically anyone at DSS or Medicaid can do anything about that. We just have to let them know that there's a change coming and it's going to be a material impact. Are they going to do a crosswalk? What are they going to do?
Yeah.
So that these providers can get a commensurate RVU or what they used to have in back in the day. So I think there needs to be a broader conversation. And I think it is mainly with physician compensation, who are the folks that are aligning the RVU units to whatever is being put out there.
If I could try
So
to
I
help.
think that's probably where it needs to start. Just my 2 cents. But
Yeah, no, I think that makes sense. What you're saying about a crosswalk. I think that may be something they have to look into then. But that's a very good suggestion.
Yeah,
Try to
I'm not
help
sure that
the
DSS
DSS
will be
folks
able
here
to
a
help
little
us
bit.
with that because they're going to be, just, using the same codes. I don't know what they could do on our end to because you guys are going to make it uniform for everyone, right? So there's not going to be any.
If I could try to help here,
Yes.
if I could try to help the DSS folks, this is an internal discussion, obviously, for your practice rather than a
Yeah.
DSS issue.
Yeah.
But remember that if you're all these triggering events that you're billing, carry RVUs. And so what you're going to see is that there are RVUs being generated for prenatal visits and for any other encounters that weren't being generated before. I don't know if it's going to make up the difference. I didn't actually know what the RVU was for global versus delivery only. But in general, for the other insurance companies out there that run things the way we're used to, they don't want us to unbundle stuff because in general, unbundling gives more RVUs than bundling. So I don't know how it's going to work out. You'd have to find out what the RVUs are for prenatal visits, but there are codes, and hopefully it would work out to allow you to do your internal calculations on how you're going to pay people.
Thank you.
Thanks, John.
Thank you very much. Yeah, and just for you guys, RVUs is basically, kind of that measurement system that they're using to assign healthcare services costs, and stuff like that. So there is a material impact, and the question is, like the gentleman said right before, is what does that look like on the compensation side?
I just want to add, some, I guess, key point from our perspective. So when we calculate the case rate, however many global codes you've used historically is already part of it. So from the, practice perspective, you should not see a financial decrease because, let's say 95% of your historical episodes are under the bundled, like the global code billing. That will be reflected in your revenue. Obviously, we cannot speak on the funding distribution among you all, among all the AVRS or providers, but those financial, income from your perspective should be there, should remain consistent.
Yeah, and like I was saying, that's where there are many different levers. So I guess that lever you guys are saying it's pretty much the same. It's the other lever that we need to find out about and what the impact is.
Definitely.
Which is that physician compensation, that direct physician compensation.
Yep.
Any additional questions? Okay, seeing none, I think we can go ahead and end early. If questions do come up, please don't hesitate to field those through your CHN PS representative. We're happy to answer your questions. We'll likely schedule another provider forum or office hours in December as well. So more to come, but thank you so much for your time.
Yeah.
Thank you.